Well, welcome everybody. This is our last quarterly webinar for 2023. This morning, Alysia Siegel is going to give a presentation about her work applying merit in populations exposed to trauma. As just I guess a little housekeeping note, or kind of thinking about moving forward. If you have a research project or a special population that you're interested in doing one of these at some point in the future, you might reach out to Emily Gagan or Kelsey Hewling or myself. We're in the process of getting the programming committee for the Institute up and running and thinking about content for these and other things. So if that is something of interest to you, please reach out. And I think there are still a couple spots available for 2024. But otherwise, I'm happy to turn it over to Alysia.
Well, thank you. So many of you know me, but for those who don't, I'm Dr. Alysia Siegel. I'm a board-certified clinical psychologist involved in teaching and clinical consultation for merit. And I'm working at the Bay Pines VA in a PTSD clinic. I trained with Paul as a practicum student where I was introduced to merit. And as I had a pre-existing interest in PTSD work, I have been thinking about how the two could go together basically ever since. And so I'm really excited to share my thoughts and experiences with you today about this idea of integration. So it's important for me to note that the contents and views of this presentation do not represent the views of the Department of Veterans Affairs or the United States government. And I have no commercial or financial relationships to disclose. Because every talk needs some objectives, it's my hope that at the end of our time together today, we'll be able to explain the theoretical relationship between metacognition and PTSD, identify how to integrate merit when conducting evidence-based psychotherapies and empirically supported treatments for PTSD, and finally, as an added bonus, identify the utility of merit for an interdisciplinary team. I want to start off with a statement Paul Leisker made during a merit consultation call a long time ago that I thought would be relevant to this topic. When you grasp the emptiness of life, what are you supposed to do? And I wanted to pose this question not only because I think it's relevant and because I credit him with much of my approach regarding integrating merit and trauma work, but also because I think it captures an inherent challenge individuals who have experienced trauma and related distress wrestle with. Next, we'll transition to some support for using merit in populations exposed to trauma. But before we do, it's important for us to think about how to define trauma, as it has become a very popular term used to describe a variety of stressful and upsetting life events. So to get us on the same page for the purposes of this talk, I'll be utilizing the DSM-5 TR definition of a criterion A trauma, meaning exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. So directly experiencing the event, witnessing the event in person, learning about it happening to a close family member or friend, and then repeated or extreme exposure to aversive details. And when learning about a trauma occurring to a loved one, the actual or threatened death must have been violent or accidental. And then in the case of repeated or extreme exposure to aversive details, electronic exposure actually does not apply unless it is work-related. For merit, the term metacognition is really defined just as a reminder for us as the capacity to use knowledge about oneself and others to manage distress and psychosocial or psychological challenges. This is a term that's really viewed as distinct from terms like mentalizing or social cognition because of the synthetic integration of each capacity rather than the correctness of the discrete judgments about oneself or others. So in other words, these ideas are really, and capacities are really intertwined and generated by the individual. And of course, we have our core elements of self-reflectivity, understanding others' minds, mastery, and decentration as the components of metacognition as defined by Merritt. Next, let's think about the theoretical interaction and relationship between metacognition and trauma, as I believe this may support the use of Merritt. Metacognitive deficits may arise from the interpersonal nature of trauma. And in fact, most criterion A traumas involve other humans. So in this vein, areas such as S, self-reflectivity, and O, the ability to understand others' minds, I think may be particularly impacted. And this is because the trauma essentially poses information that's very difficult to integrate. For example, I previously thought I was able to keep myself safe, but now I must be to blame for what happened and I have no ability to protect myself. How does a person really reconcile that? Or as an alternative, I previously thought others were trustworthy, but now after experiencing harm to my physical safety, I don't know who I can turn to. And once again, how can that be reconciled? Furthermore, experiencing trauma may diminish metacognitive capacities because it may make it threatening to place oneself in a vulnerable reflective position. And I think this can create challenges entering and engaging in psychotherapy or forming the therapeutic relationship in therapy. Additionally, if a person is isolated and avoiding, as is a hallmark feature of PTSD and as is a common reaction to trauma, the person is not actively going through the process of reconciling conflicting information via engagement in the world. They are also, if avoiding internally, so like avoiding thoughts or feelings about the experience, they're not really integrating that traumatic experience into their life story, which we know is a very important process in gaining increased metacognitive capacity. And finally, the extremely stressful nature of trauma can play a role in the development of psychosis, which we know involves deficits in metacognition. So in addition to the theoretical evidence for the use of Merritt in this population just discussed, I have also thought about how overlapping experiences of schizophrenia and PTSD may provide further support for its use. Now, as a caveat, it's certainly the case that individuals struggle with these disorders concurrently, but there are other mental health concerns that we encounter as mental health professionals that involve histories of trauma. However, to really assist with the comparison, this will be my area of focus for now, and I'll speak about the two concerns in a more separate manner at times. In both mental health concerns, there exist altered perceptions of others in the world. So in PTSD, this may be reported by patients or clients as seeing the shadow of an individual involved in their sexual assault, while in schizophrenia, this may manifest in the form of formal hallucinations not connected to a specific event. Withdrawal and isolation from loved ones is common. For individuals with PTSD, this is the product of external avoidance and emotional numbing, while for individuals diagnosed with schizophrenia, this can be because of the alienating effects of aberrant experiences. And for both populations, gestures of care and warmth, which are not received as such, may also contribute to this idea of retreating. Individuals with both mental health concerns may engage what may be labeled by therapists and mental health professionals as unsavory behaviors. I think of these behaviors as really the externalization of distress in the form of substance use, risky or impulsive sexual behaviors, etc. And such behaviors may reflect poor metacognitive mastery. Functional challenges in the day-to-day may operate for both concerns. For example, due to being triggered by trauma-related reminders or high levels of suspiciousness, everyday tasks such as going to the grocery store may be very challenging. Another area of overlap is profound emotional pain. And psychotic experiences serve to cover up this pain in individuals with PTSD. They might engage in avoidance so as to reduce distress and kind of mask that pain as well. Also, this idea of unsavory behaviors might be engaged in once again to really push loved ones away and really further reflect the severity of emotional pain, depending on the kind of behavior. Both mental health concerns involve intangible and tangible losses. Intangible losses may include the loss of faith, the loss of purpose, the loss of sense of self, and the loss of physical safety, and the related ideas. And tangible losses may include the loss of career, the loss of relationships, loss of military service, loss of housing. In both populations or mental health concerns, dormant emotions may show up as emotional numbing in PTSD, whereas flattened affect may be the presentation within schizophrenia. It is not that the individuals suffering from these conditions don't have the emotions, but really instead they are not expressed. Also, in both populations, there exists a sense of otherness or feeling misunderstood. Once again, experiences of trauma provide information in stark contrast to previously held beliefs about the world, resulting in further alienation. Loved ones may experience confusion as to why going certain places is challenging, making the person who experienced the trauma feel separate from their closest circle. And within schizophrenia, as altered perceptions and aberrant experiences operate, family members may struggle to relate to their loved ones and vice versa. For a variety of reasons, anger at the world, I think, is another shared area. I think this connects back to losses, emotional pain, and overall disappointment. Relatedly, desires to destroy might be present, and these might be directed towards oneself or one's overall life. And finally, for different reasons, paranoia or suspiciousness, being on guard, can be present as a mechanism of protection from anticipated or perceived danger. Transitioning to some more concrete support, literature on metacognition and PTSD further suggests merit may be useful in populations exposed to trauma, and even more specifically, individuals who are diagnosed with PTSD. A 2015 study explored what else may account for the severity of symptoms and concurrent distress that are not fully explained by trauma severity in individuals diagnosed with PTSD. More specifically, whether differences in metacognitive capacity were related to levels of emotional distress, avoidance, or emotional numbing and hyperarousal symptoms was examined. And participants were 40 adults with a confirmed diagnosis of PTSD, and they were compared to some other groups. Results revealed that the PTSD group had better ratings of overall metacognitive capacity than the schizophrenia group, and specifically poor levels of metacognitive mastery, or the ability to use metacognitive knowledge to respond to challenges, than the HIV group. Within the PTSD group, poor metacognitive mastery was associated with greater distress and higher hyperarousal. Emotion recognition, or the ability to identify and label feelings, was not connected with distress or symptom severity. So these results support models in which symptom severity in PTSD is related to the extent to which persons can use knowledge of themselves and others to find ways to respond to distress that match their own unique needs. This also means how a person responds to a traumatic experience in its aftermath, and the extent to which the response is destructive versus meaning-making oriented can influence the severity of distress they experience and how their alarm system responds to anticipated danger. A 2016 publication that I have the good fortune of contributing to sought to further investigate whether the connection between metacognitive capacity accounted for reactions to trauma independent of psychopathology itself. And here, participants were 51 OEF veterans who were diagnosed with PTSD related primarily to a combat index trauma. Greater levels of negative cognitions about the self, a type of trauma-related belief as measured by the post-traumatic cognitions inventory, was related to higher symptoms of depression and PTSD symptoms. Of note, examples of such cognitions include I am weak, I feel like an object. And moreover, negative cognitions about the self were also related to lower levels of mastery. Greater levels of self-blame, so for example, the event happened to me because of the kind of person I am, was linked with greater levels of depression and lower levels of self-reflectivity. These results suggest how people see themselves and perceive the world is related to how they respond to psychological problems. And additionally, the extent to which they blame themselves, which is associated with very painful side effects, such as guilt and shame, may lead someone to be reluctant, I think, once again, to engage in relationships or psychotherapy. So essentially processes in which self-reflectivity is required. So now that we've hopefully made the case for using merit with populations exposed to trauma, and more specifically PTSD, we'll talk about merit and PTSD treatment. We'll start by examining the overall format of merit sessions and evidence-based psychotherapy or empirically supported treatment sessions for PTSD. So as we know, a merit session includes 8 elements. So the agenda, inserting the therapist's mind, eliciting narrative episodes, identification of a psychological problem, the therapeutic relationship, attending to that, and then evaluation of how the session went, and stimulation of metacognitive capacities, including assessing for decentration throughout. And these elements, perhaps with the exception of the evaluation component, do not necessarily need to occur in a linear order. I think that we've all experienced that there's a fluidity in the session as a whole, and the focus is very much on the individual before you. Now, looking at the general structure of an evidence-based psychotherapy or empirically supported treatment for PTSD, we see less overall elements, which does not necessarily mean less specific tasks. The agenda is really based in, maybe somewhat based in what the individual wants to discuss. However, this term agenda is really drawing from CBT language, where you are either informing or collaboratively identifying what is going to be covered in the session. There's a review of out-of-session work typically, and the actual intervention component may vary depending on the treatment that you're providing. It may involve cognitive restructuring or recounting the trauma memory, depending. There would be processing to varying degrees of depth, depending on the specific treatment, and then a summary of what was taught, learned, experienced to some extent, etc. And the conclusion of the session involves the assignment of out-of-session work to reinforce skills and shape behaviors. Evidence-based psychotherapies and empirically supported treatment sessions for PTSD clearly involve greater step-by-step progression, almost like list-like items, and the structure and time requirements, I think, extend to out-of-session as well. So in these instances, I think it may be easy for therapists and patients to get in the weeds about the numbers in terms of their anxiety rating or the worksheets themselves, rather than relating to one another. Therapists may, in moments of discomfort, be able to hide behind some of these tasks, and maybe also more primed to experience disappointment or frustration when assignments are not completed or the quote unquote right thought is not produced. I think
that's right. I forgot you were doing, okay.
There's also, I think, less opportunity somewhat for narrative as well and eliciting that, unless you're really attending to that particular element. And so while these last ideas and statements may create some aversion to evidence-based psychotherapies and empirically supported treatments, I actually think that those are the areas of opportunity for integrating merit. And we'll talk a little bit more about that idea shortly as well. But first, I want to provide just some more specific information about what evidence-based psychotherapies and empirically supported treatments for PTSD look like, as again, there is some variation. So in the VA system in which I work, and as outlined by DoD and VA practice guidelines, evidence-based psychotherapies, or EBPs for PTSD, are really considered the frontline treatments for PTSD and trauma-related symptoms. And I've included the most common to include prolonged exposure, cognitive processing therapy, written exposure therapy, and then some empirically supported treatments not on the DoD VA practice guidelines as frontline recommendations to include cognitive behavioral conjoint therapy and trauma-informed guilt reduction or trigger. Overall, these treatments involve structured sessions, are time limited, so around 12 sessions, though some are shorter, involve out-of-session assignments, as noted before, and are really based in cognitive behavioral principles. Prolonged exposure specifically involves revisiting and recounting the trauma memory in session and engaging in vivo exposures outside of session so as to reduce fear and build confidence. Cognitive processing therapy, which is more worksheet and writing based as it's a cognitive intervention, involves re-examining what one has been telling oneself after the trauma in a variety of areas. Written exposure therapy is a little bit shorter, consisting of 5 sessions, involving writing out the trauma memory and examining its effects on one's life. And in this particular therapy, there's no out-of-session work. Cognitive behavioral conjoint therapy is a dyadic intervention, so involving the loved one of the PTSD positive partner, so to speak. And it addresses both PTSD symptoms and relationship satisfaction simultaneously. Trauma-informed guilt reduction is another one of these shorter interventions that addresses guilt and shame specifically as it relates to trauma, and also towards the later portion of the therapy includes discussions surrounding living with increased meaning and purpose in the context of one's values. The non-trauma focused intervention recommended is presence-centered therapy. It focuses on increasing adaptive responses to current life stressors and difficulties that are directly or indirectly related to trauma and PTSD symptoms. It is theoretically based in the interpersonal disconnection and maladaptive responses that often follow trauma. The agenda is directed by what the individual wants to prioritize, and problem solving surrounding the identified themes for that particular week would occur. There is less directiveness by the therapist at times, and in my opinion, this particular treatment has the most overt similarities to Merit in terms of session structure and some of the content and just overall approach. While I previously may have painted a somewhat aversive or negative picture for these treatments in contrast to Merit, again, from my experience, integrating Merit is very plausible during EBPs and ESTs for PTSD. One starting point is to utilize the MASA upon first meeting with or getting to know the individual. And I think this tool may aid in conceptualization. And we know that having a strong conceptualization can only assist with the therapy process and may also assist in mitigating countertransferent issues that can often arise during trauma work. Within prolonged exposure, S and O, so self-reflectivity in others' minds, the awareness of that may be naturally stimulated as the trauma memory is recounted. This process may enable individuals to recognize mental states, emotional experiences, and wishes or hopes of doing more, for example, that may not have been feasible at the time of the trauma. They may also increasingly recognize how fear influenced decision-making at the time of the traumatic experience. During the processing of imaginal exposure, there may be increased opportunity to elicit narrative episodes. For example, I have often explored childhood memories or other experiences during military service that really put whatever the focus of the processing is into more context. I would also add that the ability to get nuanced descriptions via narrative episodes is a skill set that has assisted me ensuring the trauma memory is fully discussed, as individuals going through this process often will have a tendency to leave out certain details that may assist with engagement with the trauma memory. So I think that's another area in which I've experienced the approach overall being useful. Regarding M or mastery, as individuals engage in vivo exposure, they may shift from being likely to reduce distress through avoidance or constantly having others around, so M3 or M4, to responding to more actively via different behaviors or recalibrating the alarm system to recognize what is and is not truly dangerous. So closer to M5 or M6 in terms of the mass A. In cognitive processing therapy, it is relatively apparent that S would be stimulated as a cognitive intervention. More specifically, I think fallibility of thought may be developed and recognition of shifting beliefs about the cause of the traumatic event across time may also occur. As overt discussions of trust violations is built into this particular treatment, opportunities for increased exploration of the therapeutic relationship and its meaning may be increasingly attended to. Cognitive behavioral conjoint therapy may offer opportunities to gain increasing clarity surrounding the thoughts and emotions of others, as one of the interventions requires a dyadic exploration of cognitions and feelings held by each member of the dyad. And as approach assignments that the dyad would engage in together are similar to in vivo exposures, mastery may also shift as well. In trauma-informed guilt reduction, as the guilt analysis component is rooted in cognitive restructuring, and that analysis would involve concepts such as justification or wrongdoing, stimulation of S would occur for reasons that I kind of noted earlier. And in the later sessions where living in line with values is the focus, stimulating mastery can occur and discussions surrounding agency may also be available opportunities. And this is because we need to know a little bit more about why that value is important, what has gotten in the way of expressing it in the past as well. And as noted previously, present-centered therapy lends itself to identifying agendas and utilizing that as an anchor for the session as individuals engaged in this therapy keep a daily diary or log of salient issues as they relate to trauma and their everyday lives. These most salient themes are further explored in the session, and the therapist is able to investigate with the individual what their response was the last time they encountered this, and then generate alternatives based on that information. The decreased number of tasks within the session itself I think lends itself to and is more conducive to eliciting narrative episodes as well. So recovery from profound experiences of trauma, I think, is my first idea about how integrating the preconditions of merit in ABPs and ESTs for PTSD might be possible. And so this recovery, I think, is just an important tenet to hold in trauma work for a number of reasons. First, while evidence-based psychotherapies and empirically supported treatments, as noted, can be quite technical, and certain demands for demonstrating in very data and objective data-driven and objective manners is often the demand of some of our work environments. I think this notion allows us to recognize that recovery must be distinct from symptom remission. There's essentially more to recovery than numbers, and again, recovery is possible. This particular principle, and as we think about integrating it into some of these structured treatments, should not involve the fragilization of individuals who have experienced trauma, but instead the recognition that they can really write the rest of their story independently. Individuals throughout evidence-based treatments for PTSD must be seen as active agents in their own recovery. So it's very important to recognize that we cannot pre-prescribe what we want for the life of someone who has experienced trauma or is experiencing PTSD to look like. When individuals avoid or use substances, we don't want to say, just stop that or impose our vision for abstinence on them. It is really important to see that those behaviors and the intention behind it is based in the quest for relief rather than surface level chaos. Thinking of the therapist as an active consultant, it's important to remember that the relationship should be as non-hierarchical as possible. And it's really important to think with the individual rather than think at them. Evidence-based psychotherapies may not naturally lend themselves to reciprocal dialogue, but it is important to find opportunities to include this principle even when completing a cognitive restructuring worksheet. It's also important to maintain the recognition that experiences can be understood. So why individuals respond to trauma with chaos or in ways that we might not if we had experienced the same, that can be understood. Why the trauma itself happened can be understood. That understanding may involve recognition of the fact that there isn't one specific way of knowing why the event happened. There's not one specific explanation. That really may be the explanation for the traumatic event occurring is a large amount of uncertainty. And this idea of all experiences being understandable, I think is particularly important for decreasing self-blame and addressing guilt and shame more specifically. Awareness of pain is also inherent to trauma work, and such awareness is important in the therapeutic relationship because gestures of care and warmth may be experienced as threatening or even seductive. As noted before, conversations about the violation of trust in the person's life in the past may be important and may also explain difficulties in relating. And then furthermore, and more importantly, I think as individuals come to the recognition there may have been little they were able to do to prevent the trauma from occurring, it is important to let them grieve that and experience the vulnerability and helplessness such awareness brings. I can think of moments where in discussing what it would mean to feel less guilty, or towards the end of an episode of care where we might anticipate, oh, the person's experiencing more relief, they should be happy about this, that they're actually still very much struggling with, do I continue down this path of relief, or do I kind of return to the distress and avoidance that I was engaging and experiencing before? Because relief and recognition at times of our humanness and powerlessness can be very, very painful. So brushing these moments aside, rejoicing instead of sitting with those moments, I think it has the possibility to further stunt metacognitive shifts. And once again, it is very important to be aware of. And finally, stigma is certainly present amongst populations and individuals where trauma has been experienced. I can think of societal examples about the angry veteran, or the myth that very much operates that men don't experience sexual trauma. And these stigmatizing messages can be internalized and further exacerbate shame, guilt, and difficulty reflecting. And so it may be important to assess whether these are operating in the life of the person across from you, and then attend to that and intervene as well. Shifting just a little bit, I currently in evidence-based psychotherapy land, there's essentially a dilemma. In trials utilizing cognitive processing therapy and prolonged exposure therapy, dropout rates ranged from 25 to 48% of individuals. Non-response or under-response to treatment has also been discussed in the literature. So essentially, these well-vetted and well-researched psychotherapies are not always performing as expected or as one would hope. I will offer that perhaps merit offers a way to keep individuals engaged and increase mastery beyond simple symptom reduction or improvements in functioning. And perhaps it is ongoing relating, finding ways to reconcile conflicting information, sitting with pain in a somewhat different manner, and the stimulation of mastery, which involves writing the rest of one's life story, that may shift these empirical findings. To further kind of highlight how merits might sort of operate in trauma work, I'll talk about some more specific examples next. I'm going to speak somewhat vaguely about the individuals themselves to preserve confidentiality and privacy, and really focus more on the shifts in metacognition that I recognized over the course of our work together. So in this first example, I worked with a male individual in the context of recovery from sexual trauma. And this individual had previously engaged in multiple forms of chaotic and self-destructive behaviors in the form of self-injury and substance use. And he actually entered psychotherapy with me in the context of legal concerns resulting from his relationship with substances. And I worked with him in the context of prolonged exposure, again, addressing the military sexual trauma. So at the outset of our work together, I would say he was operating more at an S3 level. So capable of recognizing different cognitive operations, such as remembering versus predicting. However, this became challenging to operate or engage in when asked to discuss the trauma memory in the context of imaginal exposure. And at the conclusion of our work together, he was actually able to increasingly recognize his thoughts during the experience, and also recognize fallibility in the area of self-blame, which was more reflective of S6. In terms of O, he verbalized very little about others. It almost seemed like in the room I was not really there. He noted that he couldn't understand why his loved ones had not abandoned him already. And when I offered the thought, inserted my own mind that perhaps they wanted to stay and they saw something or thought something different than he saw or thought of himself, this was a very confusing notion. At the conclusion of our work together, he increasingly recognized the intentions and the motivations of others, and that the individual involved in his sexual assault had his own thoughts, feelings, and motivations. He also became somewhat more curious about what I thought about certain things, in a way that was not reassurance seeking, but again, genuine curiosity. In terms of mastery, I would say this individual initially was operating at a lower level of M1 or M2. He defined his psychological problem as a desire to get better and really struggled to elaborate on what this meant. His in vivo hierarchy had discrete items based on, I think, what was really suggested by other mental health providers and not really rooted in what would enrich his quality of life. He also utilized more passive and avoidant methods of coping involving not going certain places, not making decisions, and then as noted before, his relationship with substances. But as our work progressed and he discovered what he thought was dangerous was not, and that he could in fact encounter trauma-related reminders, I think he was more motivated to engage with the world, engage with his family, relate to them, and do things that he hadn't done in decades due to significant levels of fear and anxiety. So I would say he increased his mastery to around an M6 as a result. Shifting to another individual, I worked with someone in the context of a group and then saw them individually for trauma-informed guilt reduction. And this veteran also had a co-occurring relationship with alcohol specifically, and due to some other mental health concerns, and in addition to PTSD and the relationship with substances, he had extensive mental health services by the time he got to me. And so one of the things that I really thought about at the outset of our work is how might I be able to offer something that was different. And overall, in discussing the guilt he felt regarding his combat trauma, I learned that he also felt significant otherness and guilt related to his place in his family and loss of jobs as well in the past. But in getting to know him further, that there were some things that he did have an interest in and felt successful at, such as fishing. Initially, I would say in terms of self-reflectivity, he vacillated between like S2 and S3. So knowing his thoughts were his own, being able to identify mental activities such as remembering the trauma, remembering the military, but was largely confused by like any content or what was in his own mind. And at the conclusion of Trigger, which again is focused primarily on guilt and shame, he was more at an S6 level, where individuals can recognize what they think, expect, want, may not match what is possible in reality. And this was evidenced by statements like, I know I can't get my hopes up, or sometimes I think I'm such a disappointment, but now I know there are things that I'm actually doing and coping that I do feel pretty good about. And I think this was also his increased self-reflectivity was apparent in his nuanced exploration of what he wanted to do with his relationship with alcohol, and kind of identifying specific thoughts within that. In terms of awareness of others' minds, initially I was really unsure about what he thought about other people and their mental functions. But again, reflective of O2, he demonstrated awareness that people aren't controlled by other forces. And at the conclusion of our work together, he was able to really verbalize what his spouse thought about a variety of behaviors. He verbalized things like, my children must be thinking XYZ because I'm so controlling. And he also demonstrated higher levels of awareness in relation to me. So he would make statements like, I think you're trustworthy, but I also know I don't know everything about you. And in the area of mastery, his distress was very demonstrative and generalized. He talked about how it affected his mood, anger, behavior, but it was really, I think, very vague, and he wasn't defining a psychological problem specifically. But at the conclusion of our work, he was able to kind of identify the psychological problem of feeling fragmented and all over the place. This was in part due to experiences of trauma, his relationship with substances as well, where he really never spent any time with himself, and felt like there was just this profound loss of who he was. And now, or at the time of the conclusion of our work, he was going with his dog to the park. He was going to church. And so there was this element of like, and these were things that were, again, in line with his values. But he would overall, I would say we could describe that as him having some more quote unquote stability. And he would at times take, I think, agentic breaks from that, where he would stop doing those things. He would, resume his relationship with alcohol, as he did want to use in moderation. But he was, again, really making those decisions himself, and with, again, a lot more agency. Sorry about that. He also, I think, became more engaged with his wife, so disclosing a lot more things of that nature as well. And in terms of decentration, I think he really thought a lot more about how, with the traumatic experience, with some of these other significant events in his life, like the loss of employment, there were a multitude of factors, and that perhaps he was less of a target as he had initially verbalized at the start of our work together. So I will also kind of note that using merit and having this approach has assisted me in functioning and working on a PTSD team. So I think one area in which this shows up the most for me is having discussions about competing agendas amongst providers and patients. So whether this is about a medication or reluctance to engage in a certain therapy component, I think it's been helpful for me to verbalize, well, it sounds like you're really wanting this to happen for that person, but I'm wondering if they are actually wanting this. And kind of just, again, labeling and naming some of the conflicts there. I think it's been also helpful to provide education surrounding experiences of emptiness. I think, as briefly noted before, within, for example, borderline personality disorder, there's often a history of trauma. And so some of that fragmentation of self, the lack of a core sense of identity, and really kind of verbalizing that in team meetings as to why patients may be engaging in certain behaviors, I think is another benefit that I've noticed as well. Education surrounding the lack of awareness of others' minds, I think, is something else that I try to provide in relation to my colleagues on my team. So really, the idea behind this is to highlight how difficulties in relating might be the product of a deficit in this particular metacognitive capacity. And then finally, noticing how many of the ways in which patients try to solve their problems and manage distress actually have very reasonable roots, I think has been helpful in maintaining a human quality and awareness that amongst all this chaos, there's a person, and which sometimes we can lose sight of, and that you know, if I were to be in that same situation, who's to say that I wouldn't respond exactly as this patient has? So another thing I'd like to mention is that some of the statements that have been made at the conclusion of my work with patients as we've reflected back on the time together. And it's my opinion that these are the product of how I've integrated merit into evidence-based psychotherapy for PTSD, and that these outcomes and these statements are richer than what would be verbalized after a manualized treatment alone. So the first, you challenged me, you made me think about myself. I think this really reflected for this person how in examining different beliefs, like their entire identity was considered. It wasn't just about replacing thoughts, for example. The statement, "I don't feel like dying anymore," I think was not so much meaningful to me because of suicidality and concerns surrounding that, but more so this person felt rooted in their story and more likely to respond in a different way rather than self-destruction. The statement, "feeling good is uncomfortable, but I'm trying to hold on to it now," I think reflects some of that awareness of relief doesn't always bring magic and good things, but can be an agentic choice that individuals who've experienced trauma make. The statement, "I feel human again," was meaningful to me because, again, I think was a product of discussing various aspects of the person's life story and increased integration in their identity. And then the most meaningful, at least for me, I felt like I was a person with you. So not treated like someone to be churned out of an episode of care, and that really all aspects of them and their history and their story were considered. So that brings us back to this question as the inherent task and the offer that integrating merit in trauma work helps people to really wrestle with and figure out what they are supposed to do with emptiness and how they can write a different story within their lives going forward, despite some of the things that have happened. So that will bring us to our discussion, and I'll just kind of open things up as we have reached that point. And one of the places for starting might be if people feel comfortable just sharing whether they've observed similar things in individuals they've worked with who have experienced trauma, if there are any points of particular agreement or disagreement with some of these ideas, that might be helpful for us to start with.
Alysia, you mentioned in some of like the evidence-based practices that reflecting on S was really similar to merit and some of like the cognitive interventions. I was thinking a lot of people that I work with tend to have like pretty low S and don't maybe reach those cognitive interventions at like the higher levels. And I know you said your first example was about an S3. So I wonder how you work with those people who maybe struggle to like identify or differentiate nuanced emotions, or how you can get started with those treatments if S is quite a bit lower.
Yeah, I think that's a really good and interesting question, because I do think that a lot of the folks that end up coming to me just because of the nature of where I'm situated are just baseline functioning at a higher capacity. And so I think that in those instances, we might consider, before an evidence-based treatment, doing some sort of pre-work and maybe leaning into merit more heavily to generate some of the development, I think, of those capacities, and maybe laying a foundation. And I would also offer that perhaps that where someone is at metacognitively and in terms of self-reflectivity might influence the actual evidence-based treatment that you pick. Perhaps in, for example, written exposure therapy or prolonged exposure therapy that involves more narrative of the trauma memory and less putting someone on the spot to produce a specific thought, those might be, or even like in present-centered therapy, those might be modalities that may be more conducive as well.
In those cases where it seems like maybe the person's metacognitive impairments might make them not ready for some of those more discrete treatments, have you run into system barriers in making that argument for that, you know, clinically the person's not ready for that, or it's like shooting too high, we need to do something beforehand? Have you found that people have been receptive to it?
So fortunately, for me, I have found that people have been receptive. I can think of some instances in which we started on prolonged exposure, and I realized this is just not going to kind of work here, and we actually transitioned to merit sessions more heavily, and the individual engaged a lot more, and there was a lot more resistance, and my leadership was supportive of that. And I think the reason for that is because I pretty regularly provide information about merit. I've kind of shaped the people around me to kind of at least consider its existence, and also because there is empirical support. So at least in my environment, that's one of the criteria, if you will, for something to pass muster. And so I think the data itself has been helpful in maybe mitigating any potential resistance.
Do you think that beyond maybe targeting too high a level of metacognition? Is there anything in any of these protocols that you feel like is just absolutely in conflict with merit? Are there elements of it? Because you've mostly focused on ways that where the integration is possible. I wonder if you could speak to if there are any components of these protocols that you think like this is just against merit.
So my mind, and this might just be reflective of my own biases and stuff like that, I think goes to this idea of like worksheets, and some of the more, particularly towards the end of cognitive processing therapy, like the worksheets can be pretty involved in terms of the number of items that the person needs to sort of attend to or respond to. And so I think that it just creates a little bit more of this transaction and almost this like business meeting, or so that's where my mind goes to start. But I think it really is how you approach it, and whether you as the provider are willing to sort of have some flexibility while still like deliver the protocol with fidelity. And it's just about how you have set a foundation for relating with the person previously. So yes, I think that those are some of the initial things that come to my mind. But also I think there are still ways to mitigate some of that.
That leads a little bit into the question I've been kind of like turning over in my mind. I think, excuse me, from my experience with some of the like prolonged exposure and things like that, I think one of the things that might feel kind of incongruent with merit is the therapeutic relationship, that it does become more hierarchical if you have to like kind of drive the patient to like complete, you know, their hierarchy, or you're sort of guiding the session a lot more than perhaps we do in like a purely merit session.
Mm-hmm.
And so I wonder if is that like, do you find that to be challenging to like kind of switch back and forth, or like how do you kind of think about it in a way that you are kind of completing these protocols but doing it in this sense of like still wanting to attend to what the person is like, what's on their mind, and seeing it as like you're not necessarily like the teacher who's like teaching them how to manage things, but are there to like make a meaning with them?
Yeah, I think there are times where I feel like it is challenging. More so when shifting from these evidence-based treatments to more pure merit. I'm like, oh, these are the things that I had, like, there's this openness, I think, that I find I internally experience. Whereas it's like I was alluding to and mentioning before, you can very easily, if you're not take up as much space in the room, and retreat behind certain things. But I don't think it's as much of a challenge to sort of shift in the other direction, at least for me. But I think that when I'm doing these specific things, there are ways in which I try to make it to convey interest in what the person sitting before me really thinks about what it is that we're doing. For example, I try to kind of consider, as I sort of alluded to, what treatment have they had in the past? What did the provider sort of do? What did that look like? And how can I not play into that, essentially? And then I do at times leave space to talk about other things. Like I don't just go into the session while we're still going to do what we ultimately need to do. I don't just provide no room whatsoever for something that's on the person's mind. I can think of sessions last week, for example, where we spent a little bit of time, like 20 or so minutes, and that I have flexibility where I can see people for longer, in terms of the session time, talking about something else. and then sort of did the prolonged exposure session. So yeah, it's not like it's a walk in the park by any means, but those are the things that I consider and that that helped me. Hopefully that addressed you know, what you were bringing up. I will also just add that I don't think it's like a perfect match or a perfect blend all the time. So there is also that.
Do you have thoughts or research on how trauma might affect someone's decentration?
So in terms of thoughts, I would say that when someone has experienced a trauma that is so personal, it's, I think, really hard to then not think of what happens in another setting or in another relationship, or maybe because of some of those like tangible and intangible losses as like world and life events not being directed towards you. And so one of the I think things built into these specific treatments, and just maybe if you were utilizing merit as a whole, is to explore with the person what might be some of the alternate causes for other things in the person's life. And then I think also stimulating some awareness of why the system, the environment, the person involved in the trauma might be a contributing factor. And that might be a way to sort of create some shift as well.
Yeah, because I can think of like if someone experiences trauma, they could have really low decentration if they believe like the world is unsafe or people are out to get them, but then also could maybe go the opposite way if they're more isolated and feeling like the world is kind of like carrying on without them, or I think that's helpful.
Another case that kind of comes to mind and that I think reflects some of what we talk about in some of the consultation calls is like, how do we identify when, for example, psychosis or other presenting concerns or just other things are bringing people in to sit before us? How do we identify or assess for whether trauma might be kind of underneath it all, so to speak? And so I'm thinking of a case where the content of the person's tactile hallucinations was a point of discussion and reflective of possible sexual trauma. And so I'm curious from, you know, others on this call, have you noticed certain things, or how might you kind of assess the role or influence of trauma?
I think it's been the case for me, and certainly in cases that I've supervised as well, that it very commonly trauma is playing a role in the kind of general SMI, and especially like prolonged psychosis, schizophrenia. you know, I can think of a number of people, especially who had really profound disorganization symptoms, that it was well into treatment before they were able to articulate an account of a kind of discrete trauma that, of course, played a role in how things unfolded in their life. You know, oftentimes it's multiple traumas, childhood and adult. But I think it's, for me, a lot of times, you know, there are little clues in the content and the disorganization early on, and then if things go well and the person's toward integration, then a more coherent account comes out, or maybe the person gets to a place where both they're able to trust me enough, but also have enough access to their own mind to then share a story about sexual assault that happened when they were freshmen in college, or the mistreatment they experienced at the hands of their step parent when they were a kid, or, you know, whatever it is. But I would say for me, it's like more times than not, that's part of the story.
Mhm. That makes a lot of sense. Have others kind of noticed something similar, or? Some of what you were saying, Jay, made me also think about what you brought up, Bethany, in terms of, are there elements that maybe are in conflict with merit overtly? And I think some of the, you know, evidence-based treatments and more structured approaches require, and you were sort of touching upon this too, Jackie, some greater baseline organization that's needed just within the person. There's really an expectation on the front end that the person is going to sit before me and deal with this thing that has happened in their lives. And not everyone might be ready to do that. And I've also thought about, like, how can I, in some ways, be deserving of receiving that information, because, you know, when we haven't worked together previously, or maybe I haven't done their evaluation, we're starting really, it's almost like a cold call in some ways. And so I've thought a lot about those moments too, and how this experience could be alienating for folks, when it doesn't necessarily need to be.
It seems like one big challenge here is that to do one of these discrete trauma treatments, it seems like the person needs to have an account of a psychological, you know, they need to be able to say, I experienced this thing and now I have this other problem. Whereas I think a lot of people that, you know, starting out in therapy with me are essentially unable to do either of those, and have kind of like diffuse or confused problems. It's just, it would be hard for me to imagine how somebody might proceed in prolonged exposure or something if they can't even articulate an account at all of a traumatic experience.
Yeah, and that is, at least for the exposure-based treatments, a trauma memory, and being able to, not always to verbalize it in full, but at least some sort of identification is indicated. And so if that's not possible, then oftentimes excuse me, selecting one of the other options would be the way to go. But that's also why I like the present-centered therapy, because there's it still offers that exploration in a way that's different than just like supportive psychotherapy, but maybe is not putting someone on the spot in that same exact way, and you're still able to think about their lives and as well.
Yeah,
But I think, oh, sorry.
I was struck when you were talking about some of those, that, some of the more discrete or manualized approaches might have a bit more interest in meaning making. I think my view, and maybe it's been kind of uncharitable, but of these have long been that the kind of the agenda from the therapist is really focused on targeting symptoms and relieving symptoms, as though psychotherapy is a kind of verbal analgesic, and maybe there's less concern about um, a shared meaning making, and maybe it's just your lens on them, but it does seem like some of them just are naturally maybe a bit more aligned with the recognition that meaning making might be an important part of the kind of psychotherapy enterprise.
Yeah, I would agree that some just naturally present that way. There have also been, developments in terms of like some newer options, things of that nature. But I do think it's about how the provider approaches it. So I like to have at least one conversation, although it ideally would be multiple, to really figure out what does this person know about themselves and their life, and what do they not know? When we think of this idea of like a goal, it's not really about a goal. It's about what is going to be meaningful for that person. And, so anything that is a intervention required of the manualized treatment, I really try to root in that exact knowledge. And again, sometimes that's known and sometimes it's not. But I think that's also why returning to like, where are we at with what we're doing, and as some self-reflectivity might build, for example, can also make these treatment approaches less pre-prescribed and less driven by me and more driven by the person.
Yeah, that makes me think of your slide too, on like the sort of people who are not having like as much of a response to the treatment as you would hope, and dropping out of the treatment as well. And that merit might be a way to like try to help offer something a little bit different, so that meaning making can be part of the approach, and it's not just sort of the very prescribed, like this is the rigid kind of structured thing we're going to do, but instead leaves room to like help people kind of think about what's going on, and hopefully have like a more meaningful encounter where it's not just targeting like getting rid of the symptoms, which might be helpful for some people, but certainly isn't for everyone.
Sure. Yeah. And I'm not going to sit here and say that I've never had someone, as I've been integrating these approaches, just not follow up or things of that nature. But it's my hope that, I am offering something a little bit different, and maybe that has some impact.
I was thinking of our Hearing Voices group, and how like voices are so linked to trauma as well. And even if it's not like the voice of a person, but maybe some of those ideas of like self-blame or just like negative views about the self from the trauma that come out in ways of voices. I've had a lot of people talk about maybe like experiences of trauma separate, and then hear voices that like say negative things about them. So I would think we try to, use meaning making in that group. And I would think in some of these treatments, the aim would be to maybe like find ways to link the two, or like integrate those, like being able to talk about the trauma, but maybe not accept those as their own thoughts or their like the result from that experience. I don't know. Does that make sense?
Yeah, I think that's a really good insight, and that ties back to one of the ways in which like Merit has assisted me on my team. So really helping to have some specific language as to why certain auditory experiences might be coming up, and how that might not be a product of psychosis, or what the sort of intersection might be, why the content might be what it is. And then what you brought up, Jackie, also made me think of someone that I worked with recently, where he did hear a myriad of voices that were pretty critical in nature. And then over the course of us, you know, integrating the traumatic experience into his life story a little bit more, those voices subsided, and then eventually were not present at all. And so I think that idea of integration and some of the fragmentation that occurs, it kind of all ties together. So I appreciate you bringing that up. I just want to also elevate the point about being able to sit with really upsetting experiences where you know, we're hearing about the like cruelty and some of the almost like evilness that people have had to encounter, and how, just based on stories I've heard about providers who weren't able to really kind of sit with that, and some of the harmful and alienating effects just within therapy that's created for some of the folks I work with, and just how I think merit, besides experiences from my own life, has really assisted me in respecting the uniqueness of people's experiences with those kinds of events. Any other thoughts, questions, just general things we want to wrap up with?
Well, I thought this was an excellent presentation, Alysia. It's really good work. I don't know if you've already started or are thinking about trying to write any of this up, and
I have not.
Is there anything published about this sort of area of intersection or integration?
I'd have to take a little bit more of a look, but I think largely what I discussed already was what I was able to most reasonably find, but there's always the possibility I've missed something, so might be something good to consider for sure.
Well, I suppose we could probably wrap up there. I don't know if we have a date set for the next one. Reed, do we have it, or is it just kind of generally be like February?
I believe it's the first Monday in February. Simone is going to present it on something around schizotypy.
Yeah. Great.
Well, thank you so much. I appreciate everyone's input and just getting to share my experiences with everyone.
Well, thank you very
Great.
much. That was awesome.
Yeah, thanks, Alysia.
Thank you.
All right, we'll see everybody next time.